we're going to look at some economic evidence or some ideas about the economic evidence presented by Don Urbanowicz, who has a 35-year successful track record with multinational healthcare companies as an advisor. He has served various leadership roles spanning general management, global marketing, sales, strategic planning, and business development, and he founded the Urbanowicz Consulting in 2011.
So probably for the next 18 or so minutes, I'll talk about patient-specific instruments and the economic perspective. Disclaimer, I do occasionally some advisory work for Materialize. Here's my agenda. I'll do a brief introduction to PSI with a focus on total knee arthroplasty. I'll review at least all of the orthopedic applications that I'm aware of. I think we discussed virtually all of them yesterday. I'll talk about the materials and methods, and basically it was a literature review. The results of at least 5 published studies that came through between 2011 and 2014. I'll look at some other benefits, specifically as it relates to the OEM, and otherwise talk about some other potential opportunities, conclusions, and questions. I hope that's okay with the audience. So very quickly, PSI, what is patient-specific instruments? For those of you who may not be as well aware, it's a matter of taking a MRI or CT scan prior to surgery of the affected patient's joint. The technology then provides a pre-op plan for component positioning. The surgeons may alter that plan based on contracture, based on deformity, based on soft tissue balancing. Then they approve the plan, and with that input, a customized disposable sterile instrument is designed. It eventually gets shipped to the hospital, and it connects with the implant that it corresponds with intraoperatively. What's the promise? To me, twofold. It's clearly intended to consistently provide accurate positioning of implants. That's important. I think the better position the implants, arguably the better the long-term clinical result. Secondly, to improve the cost efficiency of procedures. I think if you have a single patient-specific instrument, and if you could replace 8 to 10 standard instruments, that means at least 7, 8, 9 fewer steps intraoperatively, and again, that results in cost savings in terms of less OR time. Now, a potential win-win, I think it's possible, certainly for all constituents. Who are they? I think patients, surgeons, and hospitals, but I think the OEM also benefits here, especially if they can reduce the capital-intensive investments on the part of some or all of the instruments. So what are the applications? I think for me at least, what I've seen over the past 10 or 12 years on the knee side, primary knee application for PSI has been the most probably commercially and clinically relevant application so far. I think you could see by my note below that the costs and the benefits vary by application. Some of these are higher volume procedures, some are lesser volume procedures, and I think the costs vary accordingly. On the total hip side, at least primary hips for a PSI, probably it's resonated a little less with OEMs and the orthopedic community. That said, I do think a patient-specific instrument and implant for complex acetabular revisions is a very exciting area. A few notes probably on the spine side. PSI is being used now for scoliosis cases. I'll also say on the extremity side, probably shoulder is the third biggest total joint behind knees and hips. That's become pretty popular with PSI instruments. And on the ankle side, I was actually at one of the big OEMs before coming here. The conversation around the table was a 34-minute savings in the OR using PSI for the affinity ankle. Also CMF, I think we discussed that yesterday as well. So materials and methods, basically a literature review was conducted. Looked at 5 studies, 2 2011, 1 2013, 2 2014, a tad bit dated but still viable. And at the end of the day, what I'll do is try my best to summarize the cost variance between using patient-specific instruments and total knee arthroplasty versus standard instruments. I'll try to tabulate those results for you and do my best to estimate the cost savings. Now, there were 6 areas identified in these studies, 6 that were primary areas of concern for the hospital. I've listed each of those 6. I've also included a 7th, and that's clinical effectiveness. That's the one at the bottom. Let's look at OR time. So the costs were analyzed in each of the 5 studies, but only 4 offered cost savings estimates. So the per procedure operating room savings ranged from about 7 minutes to about 30 minutes per PSI procedure. That's not too bad. That's pretty impressive considering a total knee could be done between 45 minutes and 90 minutes. The cost savings, which I believe were primarily OR operational related cost savings, range from a little over $100 to over $1,300. And I also found a 2014 study that reported a more significant improvement, a 42% decrease in OR turnover time, but the authors didn't quantify. They only strongly suggested that there would be associated cost savings. Secondly, the number of surgical instrument trays. So again, all 5 identified reduced use of trays, but only 4 talked about the cost reductions, where primarily cost related to sterilization and handling. The cost savings were pretty consistent with each of the studies, and they range from about $190 or so to about $290. Hospital length of stay. Here's where we have a little bit of a fallout now between the first 2 primary areas and the third. Only 2 studies of the 5 reported on length of stay. One had a decrease of 11%, the second 17%. The financial impact, and only 1 study provided the data, was a little over $1,300. The cost of the patient-specific instrument, this is to the hospital. 2 studies reported. You could see one confirmed an increase of about $500. The second, and interestingly enough, this was a European hospital, suggested $951. My experience over the past number of years suggests that's probably a pretty good range for the cost of a PSI, at least when purchased by the hospital. Cost of imaging. I guess when I first got involved with PSI 10 or 12 years ago, I was very, very surprised as to the high cost of imaging, also as to the variables of imaging. I don't think that's changed much over that period of time. 2 publications reported on the cost impact of imaging. One was a range between $430 and $1,360. I think this was a U.S. study. There was a European study that showed an increase of only about $113. Just as a side note, I do believe, at least to the best of my knowledge, that when imaging is done on a patient before a total knee arthroplasty, it's not a diagnostic procedure. As a result, I think the time involved is almost half, and I don't think an assessment is required by a radiologist either. Let's look at OR efficiency. So one of the studies modeled the contribution margin and the caseload achieved, at least reasonably achieved, based on an OR time savings. And you could see based on only 7 total knees a week, right? And quite honestly, there are probably a select few high-volume knee surgeons who could probably do 7 knees in a day, but based on 7 knees in a week and the 210 minutes saved, they suggested that PSI could generate weekly savings of over $2,000 and an annual savings from over $100,000 based on the additional procedures. Again, that's assuming that the hospitals are efficient enough to turn the OR quickly enough to drive through additional procedures. This chart pretty much summarizes everything that I've discussed so far. I think you could look at the incremental costs of PSI versus standard instruments. You could also look at some of the cost savings. I'd bring your attention to the three columns below totals. You can see PSI is certainly in the red as it relates to preoperative costs. I think when you combine pre and intraoperative costs, it's still in the red, but only slightly. And I think when you look at the entire package, the pre, intra-op, and post-op, you could see that at least based on all the variables included, you could argue that there's an approximate $460 savings per total knee procedure where patient-specific instruments are used. And I will make a note to say that the benefit of the incremental procedural volume has been excluded from this chart. Let me just take a second on clinical effectiveness. I know my focus was on the economics. I thought I'd be remiss in not at least covering something on clinical effectiveness. The results are short-term, certainly using PSI in total knee arthroplasty, but at least some short-term observations are the following. One, PSI is associated with reduced rates of joint malalignment. I think that's a positive. A malaligned implant certainly could cause pain, and it could result in a revision down the road. Also, the occurrence of malalignment of greater than 3 degrees is a little more than twice using standard instruments than using PSI. So to me, the end result could be happier patients post-op and fewer revisions. I think one final thing worth mentioning is that when the surgeon is doing his pre-op planning and taking things into consideration like contracture, like deformity, like soft tissue balancing, I think this is a positive because it can arguably reduce some of that post-op pain that total knee patients typically feel. Let's look at it from an OEM standpoint. Again, this is independent information. This is information that I've probably accumulated over the last 10 years or so in talking to a variety of people, but I do think personally PSI reduces the number of total knee instrument sets by up to 60%. Again, I know we have a few OEMs in the room. Certainly we could argue that point. This is probably a best case scenario, but given the cost of a total knee instrument set, which could be in the $40,000 range, the total cost savings could be in excess of $20,000. So it's also a reduction in the heavy capital burden for OEMs. I mean, putting instrument sets out in the numbers that the OEMs do, it's just a tremendously capital-intensive business. So if we can decrease that in size, number, and complexity, certainly there are advantages for the OEMs. I think secondly, by reducing the implant and instrument inventory, arguably you might be able to get the sales rep out of the OR maybe a little bit more and spend less time with the surgeon intraoperatively and perhaps more time selling competitively against other companies. And I'd say finally, given the fact that in the US anyway, let's say approximately 630,000 primary only total knees done annually, 630,000. If only 10% were done with PSI, right? That's a pretty good number of data points. You multiply that by 5 years, you've got 300,000 data points in the US alone. That arguably could translate into improved future implant designs looking forward. That's very valuable. Good question. What a segue. Thank you. So my best guesstimate suggests that the penetration rate in the US is about 10%. I've seen percentage rates lower, but my argument is this. My guess is that J&J and Zimmer Biomet are around the 10% range. Stryker has gone a different direction with robotics. Their PSI usage is almost zero. On the other hand, at least from what I understand, Smith & Nephew is probably double this penetration rate. So they've done a very, very good job of penetrating the market with PSI used with their total knees. I think the number is holding steady. So if there is any decline because of competing technologies like robotics, due to sensors, due to nanospacers, right? Any of these competing technologies. I think the number is probably holding steady because if there is a decline on the part of the large OEMs, who, by the way, probably have 95% of the total worldwide market, right? I think the PSI use is increasing for the other 5%, those other 100 to 150 companies that are clamoring to maintain or grow share, right, in this competitive environment. Secondly, the clinical results, I think, have been mixed. I mean, quite honestly, from an unbiased point of view, if you look at all the data, it's mixed. You'll probably find maybe slightly more positive than negative for PSI, but I would also argue that there are a variety of protocols being used, right? There's very little consistency on protocols, and I think the accuracy measurements are another issue. And really, until we could get more precise instruments or measurements, I don't think we can really have a healthy discussion. I know there's a paper coming out shortly having to do with the unreliability of X-ray-based two-dimensional accuracy measurements, okay, the unreliability. I think the paper is certainly calling for the greater accuracy perceived by the three-dimensional CT-based accuracy measurements. So again, I think if we could more consistently have protocols and accuracy measurements, I think we could get away from the mixed reviews and certainly try to show more positive results going forward. I think finally, pricing pressures will probably accelerate going forward on the implant side, correspondingly on the PSI side, and from what I heard yesterday, even Smith & Nephew, because maybe of their high penetration rate, is getting some pushback now just on payment for imaging at the very front step of the process. So let me conclude, and I hope my time frame was reasonable. I do think that PSI can have a positive impact on hospital finances with the potential to save about $460 per total knee arthroplasty case. I think the savings do become more meaningful, certainly, if you could drive through additional procedures. Again, that's to be looked at carefully. Some hospitals have the efficiency. A Rothman might be able to do it. Others may not be. But the opportunity is certainly there. I think PSI personally, it's delivered. It's delivered on its promise to provide consistently accurate placement of implants. And I think they have improved clinical results because of that. Now, on the other hand, I'll also say that PSI needs to continue demonstrating clinical and economic value. To who? To the surgeon, the patient, the payer, and the OEM. Not to maintain its presence, its penetration with knees, but also to go beyond for other applications in the orthopedic area as well. So I thank you, and I guess we'll have some time for questions after.